Hi everyone, and welcome to our module on blood products. Let's start by talking about blood groups. So the red blood cells in our body contain surface antigens, which are proteins found on the surface of the red cells. And antibodies can form against the red cell antigens on the cells in our body. And so a person's blood type is defined by the red blood cell antigens that they possess and the associated antibodies. And we'll talk about exactly how you determine a person's blood type in just a second. But knowing the blood type of a patient is very important for safely administering blood transfusions and transfusions of other blood products. You have to match the transfusion to the person's blood type. And there are two major blood groupings that are important when talking about transfusions. The first is the ABO system, and the second is the RH system. The ABO system relates to the A and B antigens found on the surface of red cells. And patients who lack either the A or the B antigen will generate antibodies to those antigens. And this is important when selecting blood products for transfusions. You have to match the ABO type of the patient to the ABO type of the blood product you're transfusing to avoid an antibody attack on the transfused cells. To make this more clear, let's look at this table at the bottom of the screen. Patients who are blood group A possess the A antigen on their blood cells. So they won't make antibodies to the A antigen because if they did, those antibodies would attack their own cells. But they will make anti-B antibodies. So patients who are blood group O cannot receive red cells that express the B antigen, or these anti-B antibodies will attack the transfused cells. Patients who are blood group B express the B antigen on their red cells and they make anti-A antibodies. So group B patients cannot receive red cells that express the A antigen. Group AB patients have the A and B antigens present on their red cells, and for this reason they make no antibodies. They do not make anti-A or anti-B. So group AB patients are called the universal recipients because they can receive any red cells in terms of the AB system since they possess no anti-A or anti-B antibodies. And then group O patients do not express the A or the B antigen, but they will have anti-A and anti-B antibodies present in their blood. So group O patients can only receive group O red cells. They can't receive any red cells from the other blood types that express either the A or the B antigen. Group O patients, however, are considered universal donors because you can give their red cells to a patient with any ABO blood type and it won't cause a problem because the group O blood cells do not express either the A or the B antigen. Antibodies to A and B appear in the blood by about 4 to 6 months of age. They develop because of exposure to bacterial antigens that have a similar structure to A and B. So as the gut becomes colonized after birth, we're exposed to bacteria that express antigens similar to A and B. And so in patients who don't express the A or B antigens on their own red cells, they will produce A and B antibodies by about 4 to 6 months of age. The antibodies that develop against A and B are mostly IgM with some IgG. And the thing to know about IgM antibodies is they're very large and they don't cross the placenta. So in terms of women who are pregnant, antibodies to A and B usually don't present a problem if there's a mismatch between the ABO type of the mother and the baby. And that's because most of the ABO antibodies are IgM and they don't cross the placenta, and therefore they don't usually lead to newborn hemolysis. The RH system is the most important blood group system after ABO. There are more than 50 antigens that are part of the RH system, and they're all named for letters following A and B, so they have names like the C antigen or the D antigen or the E antigen. Of all the antigens in the RH system, the presence or absence of the D antigen is the one that is critical, and that's because the D antigen is highly immunogenic and can lead to antibody production. So when we say a patient is Rh positive, we mean they have the D antigen of the Rh system, and when we say they're Rh negative, we mean they lack the D antigen of the Rh system. Antibodies to the A and B antigens occur naturally by 4 to 6 months of age, but it's different for anti-D antibodies. Anti-D antibodies only occur with exposure to Rh positive cells in an Rh negative patient. So this can happen during pregnancy if the mother is Rh negative and her baby is Rh positive. Some of the baby's cells can get into the mother's circulation and that will generate an antibody response. This could also happen if an Rh negative patient was given Rh positive blood as a transfusion. So to avoid the production of anti-D antibodies, the D antigen is always matched for transfusion of blood products. Rh negative patients receive Rh negative products. Besides the D antigen, the other Rh antigens are not routinely tested unless there's a special reason to do so. And in contrast to anti-A and B antibodies, anti-D antibodies or IgG, these antibodies are smaller than IgM and they can cross the placenta. And so for this reason, the Rh system is very important in mothers who are pregnant, because if the mother has anti-D antibodies, they can cause newborn hemolytic disease. And I talk about this in more detail in videos in the obstetrics section. The only antigens we routinely test for are those of the ABO and Rh system. There are other antigens on red cells, however. These include the Duffy and Lewis antigens, also the K, N, and M antigens, but we only test for those antigens if the patient has an abnormal screening test suggesting they have antibodies to one of these antigens. And just like the D antigen, antibodies against these antigens are not naturally occurring. They only occur if a patient has been exposed to an antigen that they don't possess, either through pregnancy or through a previous blood transfusion. In transfusion medicine, there are three commonly used tests in order to safely transfuse blood products into patients. The first test is the blood type test. This determines the patient's ABO and Rh status, and I'll talk about how this test is performed in just a minute. The second test is called a type and screen. This involves the blood type test, but also a screening test for minor antibodies. These are antibodies to those minor antigens we talked about earlier, like the Duffy and Lewis antigens. And if the type and screen is positive, then further testing is done to identify which antigens are causing the problem. And we'll also talk more about this test in just a minute. And then the third test is called the type and cross match, or a type and cross. This involves matching of the patient's blood to a specific donor blood product to make sure that there's no interaction. And we'll also talk about how this works in just a minute. To determine a person's blood type, in this test you take red cells from the patient and you mix them with antibodies directed against red cell antigens, for example anti-A antibodies or anti-B or anti-D antibodies. And if the mixture agglutinates, meaning if the red cells clump together, then that indicates the presence of the antigen. So for example, you could take the patient's red cells and mix them with anti-A antibodies. If the red cells agglutinate and clump together, then that's a positive test, and that indicates that that patient has the A antigen and is A positive. If there's no agglutination, then the patient is A negative. And so you can use anti-A and anti-B antibodies to determine the patient's ABO blood type, whether they are type A, type B, type AB, or type O. And then you can use anti-D antibodies to determine the Rh type, whether the patient is Rh negative or Rh positive. In a type and screen test, you first perform a blood type test to determine the ABO and Rh status of the patient, but then you perform a screening test, and the goal is to identify if there are antibodies present to minor antigens, like those Duffy and Lewis antigens we talked about earlier. To perform a screen, you take the recipient's serum, which is the blood with the blood cells removed, and you mix that with standard red blood cells. These red cells express many of those minor antigens that we talked about earlier, like Duffy and Lewis. If the recipient's serum has no antibodies to minor antigens present, then it will be a negative test and there will be no agglutination that will occur. If, on the other hand, the patient's serum does have antibodies present, then agglutination of the standard red blood cells will occur after you mix the serum with the standard cells. And this is just a screening test to see if any antibodies are present, and patients should only have antibodies to these minor antigens if they've had prior exposure, for example, from a blood transfusion. If a patient has an abnormal screen, this means they have some antibody present to a minor red cell antigen. The next step then is to determine which antibody is present. This is done by testing the patient's serum against a large panel of those minor antigens. At that point, for any subsequent transfusions for that patient, you test the donor blood for the presence of the antigen that the patient is sensitized against. And this can be very challenging in patients with a long transfusion history. For example, patients with sickle cell disease or beta thalassemia major, they often require many transfusions over the course of their lifetime, and they can develop lots of those antibodies against those minor red cell antigens, and this can make it very challenging to identify an appropriate blood transfusion product that you can safely give to that patient. And then in a type and cross-match test, you first blood type the patient, and then you cross-match, which means you mix the patient's serum with potential donor red blood cells to make absolutely sure there's no interaction. This is the final test that's done of a blood product you're going to transfuse. So you take serum from the recipient and you mix it with donor red blood cells. Those red cells are selected because they have the same blood type as the recipient. If there's no agglutination, then it's a negative test, and this means there are no antibodies present in the recipient that can interact with the donor red blood cells. and then you know that you can safely transfuse that product. If, on the other hand, the test is positive, that means agglutination occurs of the donor red blood cells, and that means there's some antibody present in the recipient's serum that's interacting with those red cells, and that means you can't safely transfuse that product. Now let's talk about some of the different blood products that can be transfused, and we'll start with packed red blood cells. Packed red cells are red blood cells with the plasma removed, and usually this is what's transfused to patients who need red cells instead of whole blood with the plasma. And the reason this is done is because it minimizes the volume that you have to give to the patient. Platelets can also be transfused to patients with thrombocytopenia. Platelets do express ABO antigens and some HLA antigens, but they do not express the RH antigens. And it's important to know for platelets that reactions from a mismatched ABO blood type are less common than with red cells, and so sometimes ABO mismatched platelets are transfused if there's a need for platelets and the blood bank doesn't have a match for the patient. Fresh frozen plasma, or FFP, is plasma after removal of red cells, white cells, and platelets. And it's rich in clotting factors, so it's used to treat patients who are coagulopathic. It can correct a deficiency of any clotting factor. You do have to match FFP to the patient's blood type, and that's because it's plasma from a donor, and so it contains antibodies from the donor. An alternative to FFP is prothrombin complex concentrate, or PCC. This is a mixture of vitamin K dependent factors like factors 2, 7, 9, and 10. And this is being used more and more instead of FFP for a couple of reasons. First of all, you don't have to match it to the recipient's blood type because it doesn't contain donor antibodies. And also it's been shown to have a lower risk of adverse events compared to FFP. But in general, just like FFP, PCC is used to treat patients who are coagulopathic. And then finally, cryoprecipitate is the precipitate that forms when FFP is thawed. And it contains a number of factors that are important for hemostasis, including von Willebrand factor, factors 8 and 13, and also it contains lots of fibrinogen. And so you need fibrinogen to make fibrin to form blood clots. And so in patients who have massive bleeding, they can become depleted in fibrinogen, and this makes them unable to form clots. So cryoprecipitate can be given to restore fibrinogen levels. It's also sometimes used in patients who have rare disorders where they underproduce fibrinogen. Before blood products are given to patients, they're sometimes put through certain modifications, so let's talk about those now. The first one is leukoreduction. So as the name implies, this refers to the removal of leukocytes from red cell products. And this is standard practice at most hospitals. You don't need to order this, it's automatically done before blood transfusions. And the reason this is done is because removing the white cells from red cell products has been shown to lower the risk of many transfusion complications. In particular, it lowers the risk of febrile non-hemolytic transfusion reactions, which we'll talk about later in this video. It also limits graft versus host disease in bone marrow transplant patients because it decreases the production of HLA antibodies. So white blood cells express HLA antigens, and so when you transfuse white blood cells into patients, they can produce HLA antibodies. And then in patients who have had a transplant, that can lead to graft versus host disease. And then by removing the white blood cells, you decrease the risk of transmitting a virus when you transfuse red cells. So there's less transmission of cytomegalovirus, HTLV, and also Epstein-Barr when blood products like red cells have gone through leukoreduction. Irradiation of blood products is done to inactivate T lymphocytes, and the reason this is necessary is to prevent transfusion-associated graft versus host disease. So if you're transfusing some red cells and they contain some T lymphocytes from the donor, sometimes those donor T cells are not destroyed by the host immune system. When this happens, the T cells can engraft and they can attack recipient cells, and this is called transfusion-associated graft versus host disease. Some of the places the T cells can attack include the skin, the bone marrow, and the GI tract, and because they attack the bone marrow, they can cause pancytopenia, and this is often a fatal complication of a blood transfusion. And mostly irradiation is used in patients who are immunocompromised, where the host immune system might not destroy any T cells that come through with the blood transfusion. So for example, this is done in stem cell transplant patients who are being transfused or patients who are receiving immunosuppressive therapies. And then washing of red cells is done to eliminate residual plasma in blood products. This is used in patients who've had a prior allergic reaction to a transfusion. These patients are presumed to be sensitive to components of plasma, so the red cells are washed before a transfusion. Washing is also important in patients who have severe IgA deficiency. So patients who have IgA deficiency do not make IgA antibodies. This usually doesn't lead to a severe immunocompromised state, but it does mean that these patients, if they're exposed to IgA naturally, can produce anti-IgA antibodies. Most of us cannot produce anti-IgA antibodies because we have IgA present in our body, but if you're IgA deficient, you can produce anti-IgA antibodies. So if that happens, and then a blood product transfusion contains IgA in the donor plasma, that can lead to an allergic reaction and possibly anaphylaxis. So in patients with a severe IgA deficiency, the red cells are washed to try and eliminate any residual plasma, including possibly any IgA antibodies in the donor plasma. For the rest of this video, I'm going to talk about transfusion reactions. All of the items listed on this slide can potentially occur in a patient receiving a blood transfusion. And in your board exams, they're going to want you to recognize these reactions and be able to distinguish one from another. So let's talk about that now. AHTR is an acute hemolytic transfusion reaction, and this is a life-threatening complication of a blood transfusion. This occurs when the recipient has preformed antibodies in the plasma that bind and react with the donor red cells. This leads to acute intravascular hemolysis. Usually this occurs from transfusion of an incorrect blood product. So for example, imagine the recipient is blood type A. That recipient will have anti-B antibodies floating around in the plasma. If you make a mistake and transfuse type B red cells, then those antibodies will bind the red cells, leading to an acute hemolytic reaction. This presents with fever, chills, flank pain, and dark urine. All of this is due to acute hemolysis of the transfused cells. There can be jaundice of the skin with elevated bilirubin, and this can lead to DIC with coagulopathy, and that can cause oozing of blood from the intravenous sites, and this is a classic feature often described in board questions. And then when you do lab testing, the direct antiglobulin test will be positive. This is a test that's done to identify antibody-mediated hemolysis, and I talk about how it works in the videos on hemolytic anemia. But a positive direct antiglobulin test indicates antibodies have attached to red cell surfaces, and this is a key test in evaluating all transfusion reactions because this identifies an AHTR. Usually this reaction occurs either during the blood transfusion or within 24 hours after the transfusion, and the usual cause is a system or clerical error that led to the wrong blood product being transfused. And hospitals have numerous safety measures in place to prevent AHTR. This includes performing a blood type test, an antibody screen, and a cross-match like we talked about before, and then careful patient identification. The treatment is to stop the transfusion and then provide supportive care until the hemolysis resolves. IV fluids are very important to prevent kidney injury from free hemoglobin in the plasma. Patients also sometimes require supplemental oxygen, and they can require vasopressors if shock occurs. Transfusions can also lead to delayed hemolytic reactions, which by definition occur beyond 24 hours after stopping the transfusion. These are usually caused by antibodies to minor red cell antigens, not the ABO antigens. If patients have had a prior exposure to a minor antigen, this leads to immune memory, and then when they're re-exposed to one of those antigens, they develop an antibody response, but it's delayed. And so this will lead to fever and low-grade hemolysis that develops beyond 24 hours after the transfusion. Once again, the key test is the direct antiglobulin test, which will be positive. This tells you antibodies are attached to the surface of red cells. And the treatment for delayed hemolytic reactions is also with supportive care. Anaphylaxis can develop in response to a blood transfusion. This occurs seconds to minutes after the transfusion begins, and it presents in the usual way that anaphylaxis presents, with hives, angioedema, and wheezing. Hypotension and anaphylactic shock can occur. And for your board exams, you want to remember that this can occur in severely IgA deficient individuals. We've already talked about this, but these individuals are unable to produce IgA antibodies. This doesn't create a major immunodeficiency problem, but they can develop antibodies to IgA antibodies, and those anti-IgA antibodies can react with any IgA that's in the transfused product. And so as we talked about earlier, if a patient has a known severe IgA deficiency, their red blood cells should be washed before transfusion. Besides IgA deficiency, anaphylaxis can also develop in patients simply due to an allergic reaction to plasma proteins in the transfused product. And the treatment is to stop the transfusion and then use epinephrine and antihistamines, which are the standard therapies for anaphylaxis. In an urticarial allergic reaction, the patient develops hives of the skin only in response to a blood transfusion, with no other features of anaphylaxis, meaning no wheezing, hypotension, or angioedema. This is caused by plasma substances in the blood product that trigger mast cells to release histamine. The treatment is to stop the transfusion and administer diphenhydramine, which is an antihistamine, and then to carefully assess the patient to make sure there's no evidence of anaphylaxis and that the allergic reaction involves hives only. And then one special thing to know about urticarial reactions is that you can continue the transfusion after you've assessed the patient, provided the urticaria resolves and the patient is stable. Usually when there's a transfusion reaction, you stop the transfusion and you do not administer the rest of the blood product because something in that product was causing the patient to have the reaction. But the one exception is an urticarial reaction. Provided the urticaria resolves after treatment with diphenhydramine and the patient is stable, you can administer the remainder of the blood product. FHNTR is a febrile non-hemolytic transfusion reaction. This is a benign reaction to a blood transfusion. It involves fever and chills but no other systemic symptoms. And then very importantly, the patient has a normal physical exam and no evidence of hemolysis on labs. That's why it's called a non-hemolytic reaction. This is caused by cytokines in blood products. These are generated by white cells during storage, and they can accumulate in stored blood products. And this is more likely to occur with non-leukoreduced products. And so as we discussed earlier, one of the reasons leukocyte reduction is done is to decrease the likelihood of this reaction. When this occurs, you stop the transfusion, you assess the patient to make sure it's a non-hemolytic reaction and not a more serious hemolytic reaction. You can then administer antipyretics like acetaminophen for the fever. TRALI is transfusion-related acute lung injury, and this is a form of respiratory distress due to a blood transfusion. It's caused by the activation of neutrophils in the recipient by the blood products. For reasons that are incompletely understood, some patients are predisposed to TRALI because of the neutrophils in their lungs. In response to a blood transfusion, these neutrophils release cytokines and enzymes, and these damage the pulmonary capillary endothelium, causing exudative fluid loss and pulmonary edema, and that leads to respiratory distress. TRALI presents as acute hypoxemic respiratory failure that develops within minutes to hours after the start of a transfusion, and the chest x-ray will show pulmonary edema like what's on the slide here. This is a form of non-cardiogenic pulmonary edema. It's not caused by high pressures in the left side of the heart. These patients are often hypertensive because of activation of the sympathetic nervous system, and this is in contrast to anaphylactic shock where patients are usually hypotensive. And the treatment is to stop the transfusion and provide oxygen and respiratory support. TRALI usually resolves with time. It doesn't usually require antibiotics, diuretics, or bronchodilators. TACO refers to transfusion-associated circulatory overload, and this basically means volume overload or heart failure from a blood transfusion. When you transfuse blood products, you add volume to the body, and in some patients that can lead to volume overload and pulmonary edema. This presents as acute hypoxemic respiratory failure after a transfusion, and the chest x-ray will show pulmonary edema. And now these features look just like TRALI, but the thing that you will see in TACO that you don't see in TRALI is evidence of heart failure. So patients with TACO have an elevated jugular venous pressure, they can have an S3, on lab testing they can have a high BNP level. And the treatment is to stop the transfusion, provide oxygen and ventilatory support, and then provide diuresis, usually with loop diuretics, to remove the volume causing pulmonary edema. And so in any patient who develops respiratory distress after a transfusion, you want to think of TRALI and TACO. And on this table I've summarized the distinguishing features. So a fever is only seen in TRALI, and patients with TRALI have normal jugular venous pressure and a low BNP. In contrast, patients with TACO have heart failure, so they have elevated jugular venous pressure, a third heart sound, and a high BNP level. And then a TTBI is a transfusion-transmitted blood infection. This refers to a bacterial infection caused by transfusion of a blood product if the blood product was contaminated by bacteria. This will cause fever and chills. It can cause hypotension from septic shock. Usually the symptoms come on quickly within an hour or so of starting the transfusion. The diagnosis is made by blood culture and the treatment is with antibiotics. I'll finish with this slide which summarizes the different transfusion reactions that can occur. This is what they're going to want you to know for your board exams. So in a patient who has an acute reaction to a blood transfusion, the first thing to do is stop the transfusion. Then you want to assess the patient. If the problem is respiratory distress, you want to think of TACO and TRALI. Remember that in TACO there's no fever, but there are signs of heart failure. In TRALI there's a fever, but signs of heart failure are absent. If there's urticaria of the skin, you want to decide whether it's urticaria only or whether there's evidence of anaphylaxis like wheezing and hypotension. This will help you distinguish anaphylaxis from an urticarial reaction. And then if the problem is fever and chills, but the patient is otherwise well, this suggests a febrile non-hemolytic transfusion reaction. If, on the other hand, there's fever and chills, but also hypotension, then you want to think of a blood infection or an acute hemolytic transfusion reaction. In a blood infection, there's no hemolysis, and there's also no hives to indicate anaphylaxis. In a hemolytic transfusion reaction, there's flank pain and bleeding from DIC and evidence of hemolysis on labs. And then finally, the timing of the onset of a transfusion reaction can give you a clue as to the cause. In anaphylaxis, the symptoms usually begin very quickly after starting the transfusion, usually within seconds to minutes. And for an acute hemolytic transfusion reaction, the symptoms usually begin within the first hour after starting the transfusion. Beyond this, reactions that begin within minutes to hours of a transfusion have many causes. All of these things which we talked about in this video can lead to symptoms that develop minutes to hours after starting a transfusion. And then finally, remember that a delayed hemolytic reaction is going to occur days or sometimes even weeks after a patient receives a blood product. And that concludes our module on blood products.